Thank you for joining us for our webinar with Dr. Bruce Patterson. And it's going to be hosted by our Solve M.E CEO, Oved Amitay. Just a few housekeeping notes before we get started. The audience is muted and chat is disabled. But if you have any questions, please post them in the question box below. We'll do our best to answer as many questions as we can during the presentation. I want to remind you that Solve M.E does not provide medical advice. We are not endorsing the presenter or the content of their presentation. Please always consult your doctor and do not use experimental or non-FDA approved treatments without medical supervision. These webinars are for informational and educational purposes only. And finally, our webinars are recorded and are available on our YouTube channel at youtube.com/solvecfs. So you can find this one posted there maybe even later today. And with that, I'll turn it over to our host, Solve M.E CEO, Oved Amitay.
Thank you very much, Carmen, and this is really a pleasure to have this webinar today, and our focus is going to be on the immune-based prediction of long COVID and its implications for MECFS. And our guest today is Dr. Bruce Patterson. Dr. Patterson received his undergraduate training in molecular biology from the University of Michigan in Ann Arbor. He then went on to Northwestern University Medical School for training in medicine, and really had incredibly important contributions during the early stages of the AIDS epidemic. And Dr. Patterson at that time investigated the cellular reservoirs of HIV-1 and helped understand the burden of disease in AIDS and HIV. And I think that Dr. Patterson's work on HIV is incredibly important for what we're going to be talking about today. He later was named Chief Resident of Pathology at Northwestern Memorial Hospital. He has authored more than 100 manuscripts and book chapters, and he continued to do his work on HIV pathogenesis at Stanford University, where he was the medical director of diagnostic virology at the Stanford University hospitals. And currently, Dr. Patterson is the CEO of IncellDx. And I first had the pleasure of having a conversation with Dr. Patterson almost exactly a year ago when he published his very first findings on immune profiling of people with long COVID. And immediately at that time, during our very first conversation, we already hypothesized or speculated that this work could really have profound implications for our community, for MECFS, and potentially other post-infectious diseases. So we kept in touch since then. Dr. Patterson's work has been published, and really delighted to have you, Dr. Patterson, join us today for this webinar to describe not only your findings in COVID-19, but how could they really have an impact on other post-infectious diseases such as MECFS. So just to maybe very, very briefly introduce the connection, which I think for our community perhaps is almost self-explanatory. We've already talked about that a number of times. But clearly the most important symptoms of long COVID, as described by Hannah Davis and her team recently, they include pain, headaches, fatigue, brain fog, shortness of breath, sleep problems, and of course the post-exertional malaise, which is really the hallmark of MECFS. So there's an extraordinary overlap between the conditions, which make it very important for us to understand the association between these diseases. Next slide, please. So this is really the time to introduce Dr. Patterson and really invite you to present your findings, and we'll come back at the end for more questions coming from the audience and some of the questions that we already submitted before our conversation. So Dr. Patterson, it's really a pleasure to have you. Please go ahead.
Thank you, Oved. It truly is my pleasure to speak to this group. We've taken some time, but we finally have some meaningful data on MECFS. As you pointed out, let me pull up my slides. As you pointed out, the publications that you referred to mention this overlap in symptoms, and I know when we first came out with our signatures for the immune abnormalities in long COVID, the first question was, well, how does that relate to MECFS, fibromyalgia, post-Lyme, and other conditions that have the same symptoms? And that was a really profound question. I mean, even though these symptoms are common and relatively nonspecific, we really felt that there could be a connection. And I think that's really where we are right now, trying to sort through all these conditions and publish this work so we can start to identify what may be the underlying cause and also identify rational, effective treatments. And I have to admit, having lived through the HIV pandemic and been active in the research there, and probably 4 pandemics after that, it's very interesting how, as much as HIV drove the molecular revolution in medicine, which led to great precision medicine and therapeutic approaches in cancer, as well as infectious diseases, I see somewhat of a silver lining coming out of this pandemic, in that the immunology of this very complicated disease or infection has really pushed the technology of immunology. And I think we're going to see, much like we did following HIV, the deployment of molecular technologies in medicine. After HIV, we're going to see many more immunologic approaches, including proteomics and much, which is analogous to genomics, but proteomics and other ways to really define the immune system, during and post, pandemic. So I think that is one of the silver linings that's starting to come out of this pandemic, is our understanding of the immune system. Now, MECFS is very close to my heart, because a friend came to me in the early 1990s and said, I have just horrible insomnia. I haven't slept for 2 weeks. I'm a mess. I don't know what's going on. And at the time, we had just developed a new PCR panel, not only for HIV, but for 6 or 7 other viruses that included the chronic herpes family virus, CMV, EBV, HHV6, herpes simplex, varicella, etc. And when I looked at the blood of this patient, there was active CMV. And we'll talk about that a little bit later, but I really think the approach to these chronic herpes family viruses, which has certainly been implicated in MECFS, is we developed a PCR assay that did RNA to DNA ratios, which can tell you activity, as opposed to serology, which isn't so reliable in terms of saying, is it active or is it non-active? Anyway, I found active CMV, treated this patient with a short course of ganciclovir, and she recovered. And a year later, we married. So that was 25 years ago, and that was my wife. And that's how we actually knew each other, but interesting story about how we met. But on to the current topic. As we know from past, it may infect 10 to 30% of all individuals. And again, that's a tremendous number, could number in the 50 millions if you look at all the patients who are infected worldwide. We know MECFS is about 1 to 3 million patients in the United States, at least at last count that I had. PASC is, of course, a healthcare and economic emergency, But I have to admit, post-Lyme, MECFS, fibromyalgia are already in the millions in terms of those affected for each of those categories. So it is indeed also, I think, a healthcare emergency with not a lot of solutions. In this presentation, which I gave in Rome in late September, we were over 8,000 patients. We are now over 13,000 patients in our program at IncellDx. That includes Longhaulers, post-vaccination Longhaulers, MECFS, fibromyalgia, post-Lyme. And the good news is that we have this tremendous cohort from which we can draw data from and do our analyses, and also be able to think about what the appropriate treatments might be. We all know in PASC and infection by COVID-19, it's really a continuum. There's a virologic phase. There's then a very powerful post-inflammatory phase or cytokine storm, if you will. Then we have what I call the cytokine flip. We started investigating the immune system after having done 3 or 4 acute COVID trials. What we noticed were these patients were better. They were leaving the hospital. They didn't die, but by no stretch of the imagination was their immune system normal. And because of the tremendous amount of resources required just to get these patients moving through the hospital and doing the best we can with them, we didn't have very good follow-up. And when we did follow up, which was in the summer of 2020, our group found this signature that underlied the long COVID, made it very different from acute COVID. And that was really the start of saying, what exactly is going on in these post-infectious conditions that is leading to significant abnormalities in the immune system, and not only abnormalities in the immune system, but symptoms and debilitating symptoms. And like I said, at that time, it was also brought to my attention that, MECFS patients are suffering, fibromyalgia patients are suffering, post-Lyme patients are suffering. And so, collectively, that was the time when we started looking not only at long COVID, but at these other immune inflammatory conditions. With the papers that have come out, and some papers saying as many as 215 different conditions in Longhaulers, we too, this is our cohort. This was the prevalence of these symptoms in our past cohort. But you're absolutely right. I mean, the overlap with MECFS is profound. I mean, the fatigue, brain fog, myalgias, neuropathies, insomnia, and most importantly, post-exertional malaise were some of the commonalities that you just couldn't ignore. I mean, they're almost identical. So I think everybody was absolutely on the spot when they said, something's going on, because these look very much the same. So then we did start to look to the immune system. And what we did is we had developed a profile of over 150 biomarkers when we started looking at acute COVID and looking into acute COVID trials. And at the end of the day, we came upon a panel of 14 plasma markers. We had an additional immune subset profile of the actual immune cells in the blood. And so we fed all of that into bioinformatics to see exactly what was going on. And what came out was very interesting, because without too much foresight, we had a panel that represented the adaptive immune system, the innate immune system, the destructive immune system. All elements of immunity were represented in this IncellKine panel. And during our first analysis of long COVID, we were able to identify first a Longhauler index, defined as you see here, interferon gamma plus interleukin 2 divided by CCL4 or MIP1 beta. That really, with almost 98% accuracy, determined the difference between acute and chronic COVID and healthy individuals. We also went in to look at patients with severe acute COVID and mild acute COVID and developed a severity score that consisted of interleukin 6 soluble CD40 ligand, which again, I've mentioned, I've tweeted, whatever, but I've mentioned that we've been talking about soluble CD40 ligand for over a year and a half, which is a marker of platelet activation and a setup for a clotting diathesis. And so we've been talking about clotting, for a year and a half, and then finally papers are starting to come out about microclots potentially being part of the pathogenesis of long COVID. We truly believed it. That's why we put this marker in the panel. And actually, we have great satisfaction in that none of our 13,000 long hauler individuals have had a clotting event. And we saw that also in acute COVID when we were using CCR5 antagonists. We never saw a blood clot. And this is now over 1,000 acute COVID patients, and now over 13,000 long haulers. And there's reasons why we believe that. Number one, the CCR5 antagonists lower platelet activation, soluble CD40 ligand. They reduce vascular inflammation, which I think is a setup for these microclots. And I'll go into a lot more detail with the next few slides. I won't go into the derivation, but this is the first slide that we came up with that showed the long hauler score plotted against the severity score for severe patients, which you see in green, mild to moderate patients, which you see in light blue, and long haulers, which you see in yellow. And this came out in our first paper that was published in Frontiers of Immunology. Then what we did, and this is coming out soon, is we added on post-vaccination long haulers and found that patients with long hauler symptoms 3 months after vaccination also registered on the long hauler index. And in fact, most of them by AI, if not all of them by AI, if we just use dual parameters, registered as long haulers. When we added in severity score, they seem to have less of the severity score markers, VEGF, soluble CD40 ligand, IL-6, than actual COVID long haulers. So we found that to be very interesting. And in fact, when we use our combination of CCR5 antagonists and statins in post-vaccination long haulers, they actually respond in 2 to 4 weeks rather than 6 to 8 weeks for COVID long haulers. So they respond very quickly and very successfully. And I think it's because they don't have the other elements of the severity score, the IL-6, the VEGF and the soluble CD40 ligand that the COVID long haulers have. Then this was just finished. We announced on Twitter and other avenues about a month or two ago that we now had a large enough cohort of over 50 patients, thanks to the Kaplan group and Gary Kaplan's group in the East Coast, who we're collaborating with on MECFS, both diagnosis and treatment. And we overlaid the MECFS group. And they looked very much like the post-vaccination long haulers in terms of their immune profile. So heavy interferon gamma, heavy IL-2, and even higher long hauler indices than even long haulers. So we found this unique signature amongst MECFS patients that we also found respond well to CCR5 antagonists and pravastatin, and I'll show you why in a moment. But we don't have a lot of the elements of vascular inflammation that we see in COVID long haulers. So what's going on here? Well, what we found, and we just heard today that our paper's been accepted on non-classical monocytes carrying the S1 protein of COVID, 15 months, but now we're out to probably a year and a half or longer carrying the S1 protein in their monocytes, which this is the ontogeny of monocytes. There's classical monocytes who have high CD14 but no CD16, intermediate monocytes, high CD14, high CD16, also high CCR5 positive, and non-classical monocytes, which are CD14 dim, CD16 positive, and they carry this particular receptor called CX3 CR1, which is the fractalkine receptor, which is befitting their role of patrolling the vascular endothelium. And that is why in long COVID, when the S1 protein is carried by these non-classical monocytes months after infection, we see this binding to the vascular inflammation or binding to the blood vessels, which we block with statins. So we block CCR5 with CCR5 antagonists. There's also CCR5 in non-classical monocytes, and we block fractalkine receptor interactions with statins. So the bottom line is IncellDx has developed a treatment protocol that really attacks the underlying cause of vascular inflammation, clotting, etc., by using these two drugs, and it's been very, very effective. Now, as you can see, this was from our paper that's just about to come out. This blue was actual monocytes carrying the S1 protein, actually from a patient. And then the red are the intermediate monocytes, and the green are the classical monocytes. And then what we did is we actually isolated the cells which carry the S1 protein into a tube and prepared the protein and ran it by mass spectrometry to actually confirm that indeed the S1 protein was present in these cells. And we combined this with this upper tracing right here, which is store-bought S1 protein. And you can see in these patient samples, there's the same S1 peak that you see in purified S1 protein. We then went on to show the same thing in post-vaccination long haulers. Again, 6 patients with S1 protein and identical tracing to the COVID long haulers. However, the difference in the vaccination cohort is that we found not only S1 peptides, but also S2 peptides and potential S1 mutant peptides in the vaccination group. And we're going to talk about that more in our upcoming manuscript and what that may imply in terms of both pathogenesis and treatment. Now, the importance of this binding through the fractalkine receptor is that it causes angiogenesis and increases in VEGF, which cause polyneuropathy. So you can understand why there's neuropathic changes in individuals who have this type of mechanism with monocyte binding to the vascular epithelium. It also causes vasodilatation, which is this head fullness. I went on a podcast with Dr. Drew and I said, long COVID patients come in and they go, almost all of them go like this during telemedicine, which is the symbol, I think, for long COVID. And it's because they have this sense of head fullness, headaches, migraines, brain fog, ringing in the ears, or tinnitus, all caused by vasodilatation in the brain. Why is there vasodilatation in the brain? Well, it's because these monocytes carrying a variety of different proteins, in the case of long COVID, S1, these cells are actually implicated in Lyme disease, where they can carry the Borrelia peptidoglycan, which is the cell wall, in these monocytes in the absence of replicating bacteria, which is very interesting, which goes along with our, what we've been talking about is the need for proteomics and not necessarily genomics in the exploration of these immune-mediated conditions. This is another very interesting slide because when these monocytes bind through the fractalkine pathway to the vascular inflammation, what does it do? Well, it increases interferon gamma production and type 1 immune responses. This paper was published in 2013. Well, you know what's interesting? Interferon gamma and its Th1 collaborator, interleukin 2, are the numerator of our Longhauler index, which the computer spit out for us. So this was very satisfying to see that mechanistically, there's a reason why there's elevated interferon gamma and IL-2 in Longhaulers that are secondary to the binding and the extravasation of these immune cells in the vascular endothelium. So that's the mechanism underlying why we keep talking about the Longhauler index and why we keep talking about blocking the migration of these cells and blocking the fractalkine pathway through the use of statins. And it's really been the heart of our Immunotrac program, where we're looking at these immune conditions. We're looking at the basic science. We're developing precision diagnostics. They are informing us in terms of precision treatment, precision monitoring, and we now are coming out with a ImmunoWatch and Immunotrac app to help monitor both symptoms and vitals, O2, heart rate variability, blood pressure, temperature, so that we can basically categorize how we're feeling on a day-to-day basis, which actually addresses one of the questions that came up from your constituents in preparation for this talk is, yeah, we know these cytokines are different on a day-to-day basis. Absolutely, we're getting a snapshot. But what we're really trying to do is look at before and after therapy. But through a wearable, we'll be able to track symptom scores on a day-to-day basis and what drugs are taken. And if there were labs drawn that day, what do those look like, and be able to put that all in more or less a personal repository for patients to discuss. And I won't go too much into obviously the therapy with CCR5 antagonists. Here's a typical patient where we see a decrease. CCR5 antagonists do a number of things. They decrease CCL5, of course. They decrease interleukin 6. They decrease VEGF. They decrease TNF alpha, and they decrease soluble CD40 ligand. Collectively, they decrease the Longhauler index. So this is a very, very potent approach to decreasing destructive cytokines. TNF alpha is a classic example. Interleukin 6 is another example of organ and tissue destructive cytokines. And of course, like I said, the one activity of VEGF that nobody ever thinks about, other than the fact that it promotes blood vessel growth, is that it causes neuropathy. You know, in every single one of these conditions, there's neuropathy. And I would say 85% of Longhaulers have elevated VEGF. And we're seeing a lot of elevated VEGF in some of our MECFS patients. Again, we published a lay article in ASHI journal where we related different cytokines to different symptoms. And so by doing this, what I just said about what drugs target which cytokines, this chart allows us to say, okay, which cytokines are responsible for which symptoms, so that we've actually closed the loop between cytokine elevation, symptoms, and therapy, so that we can direct therapy towards symptoms and relieving the cytokine abnormalities that we're seeing in these inflammatory conditions. You know, I think everybody's, for all these conditions, they've been treating symptoms. You got this symptom, I'll treat it this way. You're at high heart rate, I'm gonna give you a beta blocker. You have pain, I'm gonna give you gabapentin. Well, you know what? At the end of the day, if we understand what's underlying all these symptoms, I think we can do a much more effective job at treating the cause, as opposed to just solely treating the symptom. I mean, we can make you feel better. I mean, a lot of people, steroids make you feel better, but the minute you take the steroids away, the symptoms come back. So IncellDx focus has really been on treating the underlying cause and restoring the immune system to normal. And that goes for all the conditions that we've been talking about today. Yes, we also want to address underlying etiologies, because potentially in CFS, we have underlying chronic viral infections that we have to treat with antivirals. I think that's an important addition to our therapies directed to the immune system, to also have therapies directed at whether or not you have a chronic virus, and is there a way to keep that from reactivating under certain circumstances. And clearly in COVID, what we found in what we published in our first paper is during acute COVID, there was tremendous decreases in the CD8 T cells. So it's not surprising to me that there would be reactivation of these chronic herpes virus family viruses, EBV, CMV, HHV6, simplex, varicella. There's no doubt it's part of it. Do we, in our 13,000 long haulers, do we see a huge percentage? Not really. Do we see it? Absolutely. And we did publish another paper about a year ago that showed that in a patient 90 days post-infection, still had replicating virus, still had very low CD8 counts, and indeed had reactivation of EBV. So yes, can that be something that complicates long COVID? Absolutely. And it's one of the reasons why I want to bring back the assay that I developed when I was at Stanford, which was to do RNA to DNA ratios to show activation of these chronic herpes viruses, and not rely on serology to decide whether or not there's reactivation. Then in that case, you use the DNA as, these are all DNA viruses. You use the DNA as the denominator, and then you look at changes in the amount of RNAs that are produced during reactivation. For instance, IE3, IE1 to IE3 in CMV would be a good example. Okay, so we are working on that solely to address the individuals who might have reactivation of their chronic herpes family viruses in these conditions. And I won't go into much detail. I want to focus on the questions, but this is our watch and app. It's going to be launched this month. And Susan can get the website out, but it allows you to track the severity of your symptoms, allows you to basically categorize the medications and doses, or any changes of doses. It'll measure blood pressure, body temperature, heart rate, blood oxygen, heart rate variability, be able to provide a dashboard that you can overlay with symptoms, just as a way to basically journal your day-to-day journey, and again can provide a output of your changes in whatever parameter you want over time. And that's really I think the next big piece, because we understand that these diseases are different on a day-to-day basis. They wax and wane. And when we see patients at 4 weeks, we're really looking at, in general, over the past 4 weeks, what has been your improvement on this particular regimen? But I think this might allow patients to journal their experience over 30 days and say, well, you know what, I had a bad day here, but you know what, I went mountain climbing the day before and the next day was a disaster, right? I mean, we hear those stories. And again, this time of year, we're dealing with other seasonal viral infections. And I'll tell you, parainfluenza virus, before there was ever a pandemic, when I was at Stanford and somebody came in and said, oh, I have just debilitating fatigue. I've been sick for 3 weeks. I don't really have a fever. I can barely move. I have a headache. My fever's maybe 99, but not so bad. And I didn't even have to do a diagnostic. It was parainfluenza, right? So parainfluenza, you can actually throw in the category of a seasonal virus that usually lasts for a long time, 3 to 4 weeks in some cases. You don't think you're sick, you don't think you were exposed, but you have it. And by 3 p.m, your head's down on your desk and you can barely move. That's parainfluenza. That's rampant since September. So, the other thing to realize is a lot of these inflammatory conditions are going to wax and wane and get worse with other, someone told me the other day, third-party infections. So as we're trying to think, we're so COVID focused that we're down to calling influenza and parainfluenza third-party infections. But I think it can exacerbate a lot of the symptoms in all of these inflammatory conditions. And I think, I really want to leave it there. I won't go into any greater detail. We're looking at, one of the questions is why do some people get long COVID? Some people don't get long COVID. We're actually looking at the fractalkine receptor. There's fractalkine receptor polymorphisms. There's different levels of fractalkine receptors on their monocytes, maybe with low expression or a mutation where they can't bind as well as normal. Maybe those patients don't get long COVID. Maybe they don't get these inflammatory conditions. We're at the tip of the iceberg. I think we're starting to make some headway in terms of MECFS and some of these other inflammatory conditions. We certainly have a treatment regimen that we're anxious to get into trials, but we know anecdotally has been working quite well. And I think what I'll do is leave the rest of the time for questions, and I'll leave it with this new figure, which will be coming out soon. We're just going to overlay post-Lyme on this, and we're very excited about writing this up quickly and getting out there about the relationship between these post-infectious inflammatory conditions. There are similarities as much as there are differences, and I think we can take advantage of the similarities to provide rational approaches to therapy. And I think I'll leave it there. Thank you.
Thank you very much, Dr. Patterson. This was incredibly interesting, and I think that the way you connected the dots is something that we were all very much interested to hear, and certainly are eager to hear more. I'll start maybe with a few questions that came from during the talk from the audience, just to clarify. I think one specific question was you were showing the table with the cytokine levels and the various symptoms. How should we read this? What are the numbers, or they're just the raw data for the cytokine level? How should we read those tables?
Yeah, we actually developed much like you develop normal ranges for analytes, we developed ranges for every single cytokine for every single symptom. So for instance, we know if you have a VEGF over 30, you're going to have a peripheral neuropathy, or if there's a IL-6 over 8, you're going to have joint or muscle aches. So that was the and it's actually out in a journal called ASHI. It's on our website, www.covidlonghaulers.com, where you can actually see it in much greater detail and in larger print. But I think that was a really important study that we undertook to get a sense of what levels of what cytokines can we relate to the various symptoms, because now we know which drugs target which cytokines. So that's really helped us from the chronic COVID treatment center to target the different target the different cytokines.
So you're using that to really specifically tailor the treatment.
That's right.
Yeah. So speaking of treatment, of course, we would all of us would, and I'm sure that many other people would love to see the results. Are there any plans to publish the data that you refer to now of thousands of people with data on and treatment results?
Yeah, so our publication plan, and again, we're so busy, and we've never hired a ghostwriter, and I think we've gotten 6 papers out in a year, which I think even when I was in academia would have been a good year. But we're also, managing all these patients. But, our publication plan is, number one, I think the post-vaccination Longhauler paper is almost finished being written, so that'll go out. The similarities in machine learning and AI profile of all these conditions, as soon as we add in the post-Lyme, will be next. That'll be a short paper. But I would say all of 2022 is going to be focused on outcomes. The outcomes of our treatment of long COVID, the outcomes of our treatment of MECFS, post-Lyme, et cetera. We have all that data. We're ready to write. And then, of course, about a month ago, we announced the first trial site and co-investigators on our randomized controlled trial for treatment of long COVID with a combination of CCR5 Antagonists, Maraviroc, and atorvastatin, so a statin. So yes, we're getting there. There's so much to write and and also treat. We're not in, the problem is, it's not a problem, but we're not in academia. I mean, our livelihood doesn't depend on publication, although I think I've said from day one to our team, it's extremely important that we get all of our data out there and peer reviewed. But again, it's not like we're in academia and it's publish or perish for us. So we have to kind of sit on both sides of that fence, but we'll get everything out. But next up, obviously, I think as soon as January 1 hits, our main focus is publish the data that we have.
So you mentioned the randomized controlled clinical trial. I think that's really wonderful, wonderful news. Obviously, we applaud your urgency in applying your translational research and and treating patients based on those results. But ultimately, to make this available and accessible for everyone, we would need to see those kind of well-controlled studies. So it sounds like this is already underway. What can you tell us in terms of the timelines or expectations of when these data could become available?
Well, again, I think our approach to long COVID was this is a pandemic. Should we wait 18 months to start treating with repurposed FDA-approved drugs while still maintaining the do no harm mantra that we all have as physicians? And I think that's what we wanted to do. I mean, but your point is well taken. We also want to do it in the right way and obviously have that validation as well to do a randomized clinical trial. And I think the great thing is we've just had so many great collaborators. We have a network of physicians across the United States that numbers over 150. We probably have 10 huge physicians groups that are also collaborating with us. I think with collaborators such as the Kaplan Group and Gary Kaplan doing a trial on MECFS can get organized very quickly with the regimen that we've been using. So I don't think they have to go in series. I think we can do them contemporaneously. And so I don't want people to think that, oh, we have to finish up our long COVID trial before we trial these drugs in MECFS, because I think we may already be there in terms of having the preliminary data to design a very, very good trial with the appropriate outcomes. I think gathering the preliminary data has been instrumental in coming up with the appropriate outcomes.
Yeah, so we're looking forward to that, and obviously more for us to talk about how could really help to set up those kind of trials, specifically in ME CFS. Maybe going back to some of previous studies that in the area of MECFS that were published. Obviously, not a lot of data on the very early onset of the disease. There was one study in particular that I wanted to mention that came up in one of the questions that has to do with the study that was following patients who had infectious mononucleosis, specifically looking at the Epstein-Barr virus. This was one of the few studies that actually was able to come up with a similar idea of looking at immune profile. At that time, it was described as IL-6, IL-8, and IL-23 as the most important cytokines that were observed in a relatively small cohort, but nevertheless came up as very significant. And obviously, in the context of interferon, which I think, or interferon gamma, which I think is really important. A finding that you all also noted. Mm-hmm. So, what are your thoughts about those type of profiles? And just to make it clear, that study looked at patients 24 months after the acute infection. So, how do you look at those kind of studies from the past, other infections, and reconcile them with your findings? Do they point to the same pathways, or do you see different pathways emerge over time?
Mm-hmm. Well, I think it's a little bit of both. I think number one, they had the advantage of using a single etiologic agent, EBV, at a defined time point, which I think is great. We don't have the luxury of getting patients at a defined time point, or we don't always have the luxury of knowing what the underlying etiology is. Is it EBV? Is it CMV? Or something else. So, but nevertheless, we see very similar, findings. I mean, we see a lot more IL-6 and IL-8 in MECFS than we do in long COVID. That's not reflected in the Longhauler index, which is why that's not necessarily reflected in the blue dots, so to speak. But we do see that. And you know what? IL-6 and IL-8 is also, and when we write the paper, the machine learning will tell us the parameter weights. In other words, what are the major parameters driving the algorithm for MECFS or for any of the other conditions that we showed? And, I believe from looking at the data that IL-6 at least, maybe not so much IL-8, will pop up when you look at parameter weighting. And IL-6 and IL-8 are something when we roll in our fibromyalgia group, I mean, it's almost pathognomonic that you're going to see IL-6 and IL-8. So, which has been reported prior. So I don't think they're far off. I think it's just a matter of, we don't have such a defined, cohort where we said it's, this is what happened. This is exactly how many months, but they're not far off in terms of what the cytokine profile looks like. And again, I think we know CCR5 antagonists bring down IL-6 and IL-8. So you know what? We know how to treat it. And I think that's the most important part at the end of the day.
We're really at the top of the hour. And Dr. Patterson, we know you're very busy. You just told us all those things that you're working on right now. So we wouldn't want to take more time, but maybe just to use that as an opportunity to offer an open invitation to come back and share with us more exciting data as you just did. And of course, we will post the webinar and we'll try to answer the questions that we received during your presentation. But again, really to thank you for this wonderful presentation, but more importantly for all the work that you're doing on long COVID and those other post-infectious diseases. And we would really be honored to have you back.
No, it's been a pleasure, and I'd love to come back and keep everyone up to date on what we're doing. Again, I think we're just at the tip of the iceberg, and I look forward to interacting with the MECFS community and hearing their thoughts, what questions they have. I think all of that helps us steer which direction we're going in, and I think it's critical to our clinical trials that'll be coming up.
Absolutely. So we'll talk much more about that. And really, again, thank you very much for joining us today, Dr. Patterson. We'll to be continued.
My pleasure. Thank you. Take care.